Good morning. The Finance Committee will come to order, please. Good morning, everybody. All right, we've got a fun agenda today. First order of business is any citizens wishing to address the committee. There being none, we'll move on to item number 3, approval of the minutes from the May 24th meeting. Entertain a motion. Motion by Dr. Weber, second by Mr. Powell. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item 4, CFO report. And I will ask everybody, when you do make statements or ask questions, to turn your mics on so that we can get it recorded for posterity, yeah, that too. All right. Good morning, Sharon.
Good morning. How are you?
I'm well. Can't speak for the rest of the people around the table, but I'm doing great.
I'm glad to hear that, Mr. Chairman. I have a couple of updates for you today. The first one is regarding our bond rating, which we talk about fairly frequently here. About a month ago, I had my S&P annual update, and the report was published probably end of last week or first of this week. But we have received an increase from our AA- rating to a AA with a stable outlook. The report, which I will post on the board portal, will actually affirm that most of the reason for this increase was due to, and I'll read it, the application of our U.S. and Canadian not-for-profit acute care organizations' criteria that they published in March. S&P, in an effort to standardize some of their ratings, now kind of has a grid-type rating system. So, we maintained our ratios, everything was strong, but the primary increase for the upgrade was because of their criteria that they converted over to. So that's good news.
Yeah.
Yes, we will take it. It is the section, what that means is it's the section of organizations in which we fall. So there may be other industries with other criteria. So it's just their standard audit tool. Yes. You bet. The other couple of updates that I wanted to give you is mainly just to let you know where we're at in our fiscal year 19 budget process. Right now, we have received most of our input from directors and vice presidents at the departmental level. Concurrently, we're also working on some strategic items at the VP level, and over the next few weeks, we'll be trying to put those together. As a reminder, our certified tax rolls do not actually come out until the end of July, so we have about a week to get the budget balanced after the release of that number and get you those mailings. So, although I did not bring my dates up here with me, in August, you will receive your budget packet, probably the 60, 80-page PowerPoint that I go over with you at the board meeting on Friday. And then on Monday, I will be available to answer any questions that you guys need or additional information that is requested, and my team will be on standby. Thursday will be the formal presentation of that budget.
Sharon, are we targeting, or is it way too early in the process to target a margin like we did last budget or this current budget? Target a percentage?
That's my intent. I mean, you have to have a goal in order to know that you're actually balanced. So we still have so many gaps. The certified tax rolls are always kind of late in coming. We won't really have any more information on our supplemental funding, any definitive numbers, until usually mid-August, if not the 1st of September.
Right.
So those are the two big, revenue
Yeah, the
areas
variables
that we weighed on.
Right.
But we're ready to go. We have all the pieces laid out. It's just once those two numbers get settled, we have to work on the expense portion.
Got it. Thank you.
And also, in our next Finance Committee, I just wanted to let you know, similar to last year, I will be bringing a detailed explanation of where we think we're going to end up fiscal year 18, kind of where we project to end this year, as well as any major budget assumptions that have solidified by then. And that's it for my update.
Any questions for Sharon, any of these items? All
Okay.
right.
So on to May. May was actually very similar to the prior month. If you start to, and I'm starting on page 12 of your board portal, I believe. When you look at our inpatient statistics, admissions were up by about 1.3% from budget, but you can see they're also significantly up from the last month. On case mix index, we were one of the higher case mix indexes that we've had this year, so we were about 1% over. And our length of stay continues to be kind of at a steady, just above 5.1 days. That is not erasing. Let's see, clear. Okay. Emergency department visits this month are right on budget, but I'd like to note they were about 7% above the prior month. So if you look at these blue charts or blue bars once again, you can see that there's a pretty dramatic increase of 7%. And urgent, I'm sorry.
We sort of expect that though in summer months, right? Is that a trend?
Well, you can see let me erase that and clear it. You can see on the bar chart, the gray bar is 3 years ago, the tan bar is last year, and the blue bar is as we complete fiscal year 18. So, you know, you can kind of see a natural trend. The red line is not a trend line, it's actually our budget for this year. So if you can kind of erase that in your head, you can see that, you know, although we do try to use a 3-year trending on how our visits vary by month, you know, sometimes we hit it closer than others.
Right.
So I don't know that we statistically have a higher volume in the summer. You know, the winter is fairly high with a lot of respiratory. I'll have to look into that.
No,
It does tend to trend up in July and August on the other two bars. Urgent care is 7% under budget, but again, higher than the prior month by about 6%. And then our primary care and specialty clinic visits, you can see we were right on target this month for primary care. Specialty was about 7% over. And if you look at those two pools of clinic visits year to date, we are about 2.5% over. So busy in the clinics. Our observation cases were below budget. And I wanted to point out, invasive labs had another great month. If you look there in May, you can see that was the second highest month compared to March. And then our inpatient and outpatient surgeries were some of the stronger numbers that we've had this fiscal year. So we were only about 1% under in inpatient from a budget standpoint. In outpatient, we were 6% under. But again, focusing on those blue bars, you can see a nice trend up. In our mental health area, our psych days were strong. They were about 4% over. And our emergency room visits were down this month by about 8%. And then you can also see that the psych clinic continues to trend. It did come in higher than prior month. And our partial hospitalization days are continuing to be about at the same April level. So I'm sorry,
I've got a question about the site clinic visits.
yes.
Our budget lines apparently are always way over budget. Why are our budget projections just too high for psych, or what's going on?
For this last year, the psych clinic visit budget had increased from prior year by about 20%. That was too aggressive. If you look again at the graph, we are significantly ahead of where we were this time last year, kind of even on a trend basis. But we were too aggressive in what we budgeted for the clinic visits.
Okay. Will that be readjusted this year?
Let you know that Zelia,
My new
who's,
friend Zelia.
yeah, Zelia, who's been
I have
our,
her back, literally.
our VP for behavioral health for 5.5 weeks, is taking a true ownership role
Okay.
in all this. So
That's
plus,
step 3.
gives you one more
Step three.
opportunity.
One of the other issues regarding budgeting for FY 2018, it was also based upon providers being in place at a certain timeline during 2018, and some of that did not happen according to the timeline. But we also have a new leader that is aggressively changing our internal processes, as well as looking outward to increase our volume. And so that's why I think we'll continue to see the trend line going up.
Okay, all right. Thank you.
All right, thank you. So from our financial metrics, and nobody's going to be able to help me with this one. We are
Good, because the
at-
rest of the staff out there is not making eye contact with
They're
you,
so
so it's perfect.
happy.
And nobody's happy with Zelia right now. So the whole staff is going, why did you go up there? We don't do
Show
that.
off, show
So
off.
it's perfect.
Yeah, so everybody's breathing a deep sigh of relief since I've made it through the operational stats. The financial metrics, the way we look at days cash on hand in the top left, you can see here that we're kind of having our natural slope once again. And the available for operations, which excludes the JPS Future Fund that we have set aside for future construction, and any restricted cash. So what we have available to use is at 226 right now. So I will anticipate that to continue to decline through December, start to pick up in January and February. Our net accounts receivable days, which sometimes I kind of brush past this, but all this measures is from the time that we bill a patient or an insurer to when we collect on that bill and close the account is about a 49 days right now, which is very healthy for a rev cycle metric. And our FTEs per adjusted patient day, our year-end goal is to make sure that we only pay out 5.8 hours per adjusted patient day. Year to date through May, we are at the 5.64 level, so favorable.
Now, on the AR, that doesn't include like denials and things like that, or that we're adjudicating, we're trying to resolve?
No, it's just an overall average. It does include everything.
Oh, it
So
does?
as our
Okay.
denials increase, or if we're having problems with a single insurer, sometimes that will impact my days in AR
Got it.
number. And you can go back in history, and I can kind of tell you 1 or 2 months where there was a specific insurer that we were having difficulty with, or we had to hold claims for one reason or another, and that will impact my net days. But this is all in all accounts for the
That's-
medical center.
That's pretty impressive from industry standards.
What would be excellent? Good question. Curious for days.
I don't know, just in the corporate world, I mean, 30 to 38, 39 days is pretty darn.
Right.
So-
Yeah, right.
Yeah.
I was going to say. Yeah, exactly. Yeah.
You asked for that, Dr. Weber.
Dr. Weber, I need to refresh.
There is. And
Yes.
it depends on your industry, too.
I will refresh and go back and look, but we are on the lower end of, or on the upper end of good, or the lower end of really excellent. So, but I want to make sure that those standards haven't changed in the last 12 to 18 months. Okay. And our connection enrollment, we did have a slight increase of about 1%, or 271 enrollees that were qualified. And just as a reminder, there is a big turnover every month for people who are, they're approved for 12 months. And for those who are falling off of the eligibility and need to re-enroll, a lot of times that doesn't happen until their next episode of care. So even though I say we've increased 271, there are large numbers going out and new enrollees, so.
Like 10% drop off or 20%? If I were to look at the new incoming and the people who are re-upping and lost, what's the mix there?
You know, obviously it depends on the time of the year. December, we lose quite a few enrollees, but I would have to refresh my memory on that. I've looked at that about 6 months ago. It's not 10 or 20%, but.
No, it's not.
No, it's probably a couple of thousand people will drop off in any given month, and then we have to re-enroll and get new enrollees to make that graph increase.
But if I were to look at Tarrant County and say how many people would qualify, it'd be 10 times this number, right? Or not 10 times, but it'd be 5 times.
I don't know that number. The 3 criteria, once again, are you have to meet federal poverty guidelines. You cannot, which also means that you can't have any other form of insurance.
Right.
You have to be a Tarrant County resident, and you also have to be a U.S. citizen. So I don't know that I have the demographic information to say, you know, we've got 10% of the eligible people accounted for in that 38,000. I can tell you that not everyone who's eligible applies.
Sure.
So as long as they apply, they get into our system and they're eligible for primary, specialty, the drug program, so pharmaceuticals, you know, limited dental, and, you know, of course, their inpatient stay, along with any ancillary procedures that would be required in any of that span of care.
We had the Blue Book program that went through, and we figured out how many people in the county would actually qualify, did we not?
Yeah, you're going to know what your poverty levels are. And this is a really interesting statistical situation that we'll get in. And JPS, even before you and I got here and before that time, I'd always heard there's X amount of people of this poverty level, and JPS only takes care of X amount of people. And that's always a bit of a misnomer for 2 reasons. One, you want people in your connection program, so one, you get better primary care, you get them into a system, and you avoid fraud and anything else. So you go through a qualifying process. And not all people either want to go through that process or sign up for it. So just who's eligible and who we can get in to go through the process are 2 different worlds.
Right.
The other thing is when you look at who JPS is serving, oftentimes just because they're in the connection program doesn't mean that we're not serving that population. Because unfortunately, many are coming through the emergency room or other means.
Right.
And some may say, and I've heard it, and Dr. Ziegler and others have heard it too, and that is, I don't want to sign up for your connection, I'm going to pay with cash, or I'm going to do whatever, or I don't want government scrutiny or anybody else. So whatever the number is, and I don't have it at the top of my head either, but we know what the poverty levels of Tarrant County are.
Right.
You can say those are eligible, but trying to make sure that all of those went in. And if we enrolled everybody who is eligible, your commitment to a facility would be phenomenal. And I'm sure you want to support that, but the amount of buildings we'd have to build would be amazingly large.
Well, just because somebody's in the connection enrolled does not mean that we see them every day. It doesn't mean that we
Sure.
don't see them,
Right.
either way, right? Just like we have people who we're serving that are not part of connection. and
Exactly.
That we're gonna have the opposite too. There are plenty of people that go decades without seeing a doctor, right? Because they're
Right.
as healthy as a horse and never have a problem. I'm just curious.
Horses aren't that healthy, by the way, but go on.
Yeah. Healthy as a healthy horse, right? So, anyway, thank you for clarifying
Here
that,
to
all
help.
of those things for me.
So for the month of May, the medical center actually exceeded budget from a operating income. We were about $45,000 ahead of a $115,000 budget. Some of the larger variances that we can go over, some of these are kind of related. They have impacts both in revenue and expense that help offset. We did have a $3.6 million overage in net patient service revenue. And even though we are doing a really great job in rev cycle, and we are a bit ahead of budget from a standard collection rate, the biggest impact is about $2.3 million due to the URIP program. And remember that program pays us a higher payment amount, a significantly higher payment amount on Medicaid patients through our Tarrant County MCOs. So Cook Children's, Aetna, and Amerigroup all have increased rates. The backside of that is it does cost us more in IGT. So that's a new program that kind of got implemented after this year's budget was set. We also had a bit of an underage and other operating revenue. A lot of that relates to the pharmaceutical assistance program as well as vaccines for children. We do have offsetting supply underages in the drugs. If we don't provide the drugs or if those drugs are not utilized, then we don't recognize the revenue. So those are a complete offset to our bottom line. Salaries, again, they were over, but our FTEs per APD for the month were actually favorable as they have been year to date. So a lot of that had to do with our inpatient volumes and other outpatient areas. Our benefits, I wanted to point out, although we've had some detrimental months from an employee health access and cost, this month we were just about $200,000 over in health. So again, that fluctuates fairly significantly, even though we have a lot of people looking at that. It's very difficult to predict if a catastrophic case will be coming through or what that utilization will be. But we do accrue. It's not just what came through. So we're paying very close attention to that number. And we also continue to have some underages in our utility expense, as that is, we have better rates and contracts on a couple of our large utilities than we expected to have. On our year-to-date, if you look at the medical center, although we did hit our budget, we've still got $1.8 million to try to make up by the end of the year, to try to hit that fixed budget that we presented to you last year. Again, a lot of the changes that have occurred in this year's budget was some of the benefit structure as well as disbanding TCICC and bringing the URIP program on. Are there any questions for the medical center itself before I go on to a claim?
I'd like to say, Dr. Schrader was wanting to bring some of that information to MEC. And there's a way we can break it down into departments, so we need to see who's being good, who's got some issues.
So we have been really looking at the length of stay issues as it continues to increase. And we will be able to provide Dr. Schrader with whatever he needs to. We can break that down, at least, by section. May not be specifically by department, but we can get more detail than the total, definitely.
Yeah, just that we talked to MEC, that we want to bring some of this information presented to MEC so that we can see what can medical staff do to help us.
And we are working closely. Length of stay is one of those issues from a strategy standpoint as we prepare for budget 19, what assumption we want to use for length of stay. Do you keep it constant? Do we have operational things that can be implemented that will help decrease that? And I know that we have been working with the hospitalist group since they have kind of a large net, and we will be bringing, we can get you any information you need. Just let me know. So on a claim, again, billed encounters for the month continue to be a bit under budget as we fill open positions in a claim. Year to date, that underage is about 5%. Just for this month, it was 8% with some additional time away. And another important thing that we can look at is even though we're under encounters, how are we doing on expenses per encounter? So both on a month and a year to date, we're about 7% under the cost for each encounter compared to budget. So that's a nice favorable variance to have. And then from the income statement side, they came in right on budget at 1.5 million loss. And year to date, you can see that they are continuing to stay right within their budget at 9.5 million. Most of the variances for a claim have been pretty standard throughout this year because of the open positions. Our net revenue is down, our salaries are under, we have a little bit higher contracted expense. So if you have any other questions on a claim, I'll be happy to answer them. Okay. From a consolidated standpoint, if you want to look at our year-to-date number, okay, it's not going to let me draw over that, but if you look at the right side of the page, from an income from operations, we have a combined loss of $7.6 million compared to a budgeted loss of $6.3 million. So we continue to work on that $1.3 million gap. And if you look at the bottom line, right there, you can see that after interest income and other non-operating revenue, we're at a loss of about $209,000 for the entire system, compared to a budget of $658,000. Are there any other questions on May performance? Okay.
Okay, thank you, Sharon. Okay, ready to go on to the contracts?
Yes, sir.
All right. Oh, we need a motion to approve.
Oh, we do.
Motion by Dr. Weber, second by Mr. Powell. Any objections? All in favor, please say aye. Opposed? Motion passes. All right, item 5B.
So Provider Health Network is a contract that is actually a wrap network. They are looking to expand their providers that are within the DFW area. So this is not, this is for people who probably live outside of Tarrant County but have to access care when they're traveling or for a specialty care that is not provided in their home network. So that is presented for your approval today.
Okay, you've heard the description. Any questions for Sharon on this? Okay, I'll entertain a motion. Motion by Dr. Weber. Do I hear a second? Second by Mr. Powell. Any further questions? All in favor, please say aye. Opposed? Motion passes.
Thank you.
Thank you, Sharon.
I think it's going to be the second there.
Dr. Duncan, oh, good morning.
Good morning. Thank you. So I am here this morning to ask the board consider approval for us to continue our agreement between the hospital district and White Settlement Independent School District to continue care.
Basically, same terms.
It's
This
the
is just an
same
extension
terms,
of,
right.
how many, we have 18 or 17 or 18 of these?
We have 19 school-based clinics. This
19.
one is located in the White Settlement area.
Okay.
It's been open since 2006. And just to remind the board, we have gone after certification of our school-based clinics for patient-centered medical home. And we are starting to hear about our different sites, and White Settlement is one of the sites that has been certified, so.
Excellent. Great. And it's a 3-year extension?
It's a 3-year extension.
Okay. Any questions for Dr. Duncan?
I'd move for approval.
Motion by Mr. Powell, second by Dr. Weber. All in favor, please say aye. Opposed? Thank you, Dr. Duncan. Yes, sir, turn your mic on.
This is another thing that JPS does not get enough credit for around the county,
Agreed.
in that we are providing all this care at the school-based clinics. I mean, 19 of them's a lot.
It is. A lot of kids get
That's a lot.
covered that otherwise wouldn't. All right, Ms. Whelan.
Hey, good morning. I'm here with 3 contracts today. The first was with Phillips Healthcare, and this is for a contract for a point-of-service execution on a service contract for the new CT units that you approved a month or 2 ago. What we're seeing is manufacturers are asking us to obtain service contracts for the time period after the warranty expires. And by doing so, they're offering extra long warranties. In this case, it was an extra 6 months, and a good price for that when that service contract would become eligible for use. So in this case, it would be for fiscal year '21. Yes, we're talking that far ahead. What will happen is the CT units will be installed over the next 9 months. At that point, the warranty will go into effect for 18 months, and then the service contract will come in at the price we obtained today.
Got it.
So I'm asking for approval of this service contract for fiscal year '21.
Got it. And we'll spend the money this year, but it's.
We will not spend the money this year or next year.
Oh, okay, awesome. Okay, we've heard the description. Any questions for Kathleen? Entertain a motion. Motion by Dr. Weber. Do I hear a second?
Just one legal question, if I could. It's okay for us to vote on something that we're doing this far out? Because we're approving now in order for us to get everything lined up, but we're actually not spending these dollars until the actual expenditure of these dollars will be in 2 years. Kathleen, is that correct?
Mhm.
That's-
We're obligating them now.
We're
for a few-
obligating now for future. Okay. And I would second if that's.
I mean, I think you can go ahead and approve those now, as long as.
As far as the budgeting process, we need to have that so we can include it. Okay.
There is a term in there that includes that if funds are available.
Okay.
Okay,
Second.
so we have a motion. Do I hear a second?
Yeah, I'm the second.
Did you second?
Yes.
I'm sorry, I missed that. Okay, motion and a second. All in favor of the motion, please say aye. Opposed? Motion passes. Item E.
The second contract is with Siemens Medical, and this is for a purchase of a second dedicated cardiac cath lab or angio room. This room also will have additional flexibility to do vascular procedures, and will allow them to have more flexibility in scheduling. as you saw when Sharon was reporting, the increase of volumes that they're putting through that area on a day-to-day basis. So this will allow them that flexibility into a room that was already designed when the east expansion was completed. This is for $1.2 million, and it is included in the FY18 capital budget.
I'm sorry, Kathleen. Okay, you've heard Kathleen's explanation. Any questions for her? All right, I'll entertain a motion for item E. We have a motion by Dr. Weber. Do I hear a second?
I'll second.
Second by Mr. Fisher. All in favor, please say aye. Opposed? Motion passes.
You saw that within budget, Roger, I saw.
What they're now doing in Cath Labs is certain select patients with aortic valve surgery, used to be all open heart, they can now do that percutaneously.
Do what?
Aortic valve work, aortic stenosis type things, they can now do percutaneously in a vascular lab without the open heart
Wow.
surgery. I mean, that's how the technology
Has advanced.
is evolving.
Nice.
Oh, it's quite cool, quite cool.
Okay,
Thank you.
thank you for that. All right, we'll move to item F, Kathleen.
My last contract is for Intuitive Surgical, and this is a little different than we have presented in the past. This is a contract for both the purchase of $96,000 from the capital budget for 4 additional operative robotic endoscopes, and also the service contract for the new robot system. It will also allow us to do is have coterminous coverage, so that when the coverage of the first contract expires, it will be dovetailed to the service coverage of the second unit. And that coverage is $1.1 million, and that covers us through December 31st, 2022.
All right, any questions for Kathleen? Now, this one has an exception to the competitive bidding because it's intuitive. I mean, they're like the only producers, right? of
Yes,
that
that is
particular-
correct.
So we need to include that in any motion, that we include an exception to the competitive bidding. All right,
The exception is noted.
so we have a motion by Dr. Weber. Do I hear a second? We have a second by Mr. Powell. All in favor of the motion, please say aye. Opposed? Motion passes. Thank you, Kathleen.
Thank you.
While, to your point, Mr. Powell, while Melinda is coming up, any contract that we get into over a long period of time also always has a fiscal clause to it. So if the fiscal capabilities are not there, then that's not going to be a contract that continues. So it is a commitment to a contract, but not a commitment to indebting this board or any future boards to a financial situation.
It's pertinent only that those contracts which require us to show evidence.
Every
that we're-
contract we have has a
Gotcha.
fiscal viability clause
Gotcha.
in it.
Maybe this is something I can find anywhere that I just haven't looked at it. In the contracts less than 200,000, there's Caldwell Automotive Partners Police Vehicles. Do you know what that is? 115,000?
Well, I'm guessing it's the repairs on our police vehicles that we have. Go up to that podium real quick so they can hear you.
Ours.
They're ours.
Yeah, they're the districts, the hospital districts use.
Yeah, interestingly enough, we went back for a second time and attempted to get a local vendor to bid on that, and no one would.
Thank you, I was curious.
Sure.
Okay, Melinda, item G.
Good morning.
Good morning.
I'm here to discuss 2 renewals of contracts, extensions of current contracts. The first one, called Clinical Computer Systems, is really for our OBIX perinatal system. It is the system that allows us to monitor the heartbeat of the baby while the baby is still in the mother. It is the system that we've been using since we've been live on Epic, so for over 5 years, and it's just a continuation of this contract. Any questions?
Any questions for Melinda? We have a motion by Dr. Weber.
Second.
Second by Dr. Ziegler. All in favor of the motion, please say aye.
Aye.
Opposed? Motion passes. Item H, Melinda.
This contract, once again, is a continuation of a contract that we've been using for the last 5 years. It's with Conduit, but that is really the Midas Data Vision system, so you may know, be very aware of our Midas system. Data Vision is the tool within the Midas system that we use to report our core measures. Not only do we report our core measures through this system, but it also gives us comparative data about our results against other organizations. So it does allow us to see where we stand from a quality perspective. It is a tool used totally by the quality department. Any questions about that?
I'll toss in here that I'll always ask us to, whenever we have one of these things that, you know, that we're not going out for bid because somebody's got some proprietary is one thing, patented is another thing, but there is an open source world out there. We ought to be always, I hope, looking forward to trying to find ways that we don't have to be stuck with one vendor because they happen to have a patent for 20 years and then they expand that and go on, and we just kind of feel stuck there because we don't want to ever bite the bullet to do what's required to get off that highway. And I don't know anything about this technology, but I do know something about patents. I do know that there are other ways of doing things.
Sure, that's a good point, well taken.
We'll contact the patent lawyer.
Any other questions for Melinda? I will highlight the motion on this needs to include an exception to the competitive bidding. We have a motion by Dr. Weber. Do I hear a second? Second. Second by Dr. Ziegler. All in favor of the motion, please say aye. Opposed? Motion passes.
Thank you.
Thank you, Melinda.
Here's an aside for you.
Yes, sir.
Information technology. It's David Mendenhall's 7th anniversary here.
It is, really.
Apparently in a field with very high turnover, possible suicides. I mean,
Well, very happy that
Let's
he's,
just focus on the 7 years.
Yeah.
Just point out,
Chuck,
on
you're
the
not
page
looking-
of this, just
you're
say
not-
all
you're not
items
looking at me
under
for a
this
second,
will
are
be
you?
only
I'm
for
not doing
finance
that.
committee approval,
got it.
not for full.
Yeah, high turnover is a good point, too.
And then will be considered at the next board meeting.
Mr. Mendenhall, thank you for sending us all an email telling us you've been here 7 years. That's very helpful.
Now, then we can go on.
Yeah.
And how happy you are to
Yeah. Okay, item 6, the A, B, and C. It's set to, if we had a quorum of the full board, we could consider them as a full board, but we're going to consider them as the finance committee.
Correct, and then they'll go on to the full board in a few
Correct.
weeks.
So item 6A, Ms. Clark.
Okay, so I cannot express how pleased I am to be able to offer these 2 next managed care agreements. We have been in negotiations with Cigna, both for the Medicaid product, which is 6A, and the Medicare product, which is 6B, in order to have our organizations come back together. A few years ago, we had the Cigna Medicare, we were in network, and that agreement was canceled. And so I would like to present for your approval today, and we'll do them one at a time. Again, 6A is for the Medicaid managed care product in Tarrant County with Cigna Health Spring.
You've heard Sharon's description. Any questions for her on this? All right, I will entertain a motion.
You made the motion. I'll second.
All right, we have a motion by Mr. Powell, a second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. Yes? Yes, yes.
And 6B is for the Cigna Health Spring Medicare Advantage product.
Same basic description as you gave prior, right?
It is, yes. The Medicare is the one that we had been out of network for potentially the last 4 or 5 years, and this will allow those Advantage members to begin both with a claim and the medical center to become in network.
Correct. Okay. You've heard the description. Any questions for Sharon? Entertain a motion. Motion by Dr. Weber,
Second.
second by Mr. Powell. All in favor of the motion, please say aye. Opposed?
you.
Motion passes. Mr. Powell?
Mr. Chairman, a comment I'd just like to make, and I'm going to read something here because this gentleman could not be here today, but he's been very involved, and I didn't want to read this till after the board considered, the Finance Committee considered Sharon's presentation, but I'm going to read this anyway. It says, well, I'm going to include that anyway. It says, you know, I'm basically out of the city at a healthcare conference. I had a chance to talk with Sharon, and she did a great job negotiating the payer contracts that we thought was low the last time, and was able to change the payment from 125 to 106% of Medicare rate. Her team is moving in the right direction under her leadership. Please recognize her in my absence on Thursday. So again, it's from Mr. D.T. Wynn. And I know
Thank you.
D.T. has spent a lot of time with you, and he and I have been talking. I just will acknowledge he couldn't be here today, but again, it's an area he's been working with you and your staff on, and I want to pass that on behalf of DT. And likewise, Chair of the Board, appreciate all the time and the work you did, you and your staff, in getting these. So thank you very much.
Thank you. We
Chairman.
have
Thank you,
3
Ms.
staff people that work very diligently to develop good relationships with these managed care payers, and so we can keep those lines of communication open. Kelly Ford and her folks do a great job.
Good.
Thank you.
And
Thank you,
Mr.
Sharon.
Powell, if you will get that to Sharon, she'll put that on a plaque in her office, if you don't mind.
Well, I say thank you on behalf of DT, and also as Chair of the Board, I say thank you, but also appreciate DT, time he spent. He took time to provide this. So again, a good win for everyone.
Yeah.
Thank you.
Thank you, Mr. Chairman.
Thank you. Thank you, Kelly.
Okay, item C, Mr. Mendenhall, Mr. 7, number 7.
Mr. Sack.
Reached out to Celia, who sits right behind me, and told her the reason I don't wear a tie very often is it's a ligature risk for me. So we we try to reduce those here at JPS. So in front of you is a request for approval for a contract with AT&T. It's a renewal contract for many of our switched Ethernet services. That's the connection that we have from our JPS data centers to many of our locations, many of our clinic locations throughout Tarrant County. This is also an exception to competitive bid. That's part of this because we have AT&T at these clinics right now. Moving to another telecom provider would obviously be a huge hassle to the organization and probably end up in some outages that we just don't want to experience right now. This is a budgeted thing, and we're staying right within budget for FY18 for the next 2 years.
Okay. You've heard David's explanation. Any questions? All right, we'll entertain a motion. Yes, sir.
Yes.
All right, we've heard a motion. I'll entertain a second.
Second.
Second by Dr. Ziegler. All in favor, please say aye. Opposed? Are we sure we want to vote for this? I mean, 7 years, can we trust this guy?
No.
All right. All in favor, please say aye. Aye. Motion passes. Thank you, David. All right, anything from legal counsel today?
On report for contracts under 200,000 in the May time frame, there were 34 contracts that were under $200,000, and there were no contracts in the area of 200,000 to 500,000 from the May time period. So that's it.
Any questions for Alan on any of that? All right, anything for closed session? We do not. All right, and we are adjourned.
All right. Well done. As a side note, we'll call this meeting to the John Peter Smith Health Network Governance Committee meeting to order. Thank you all for being here. Are there any citizens wishing to address? Seeing none, I will move for approval of the minutes of our April 26th meeting. They're available. Moved by Dr. Weber. Maybe I can't get a second. Steve Montgomery seconds the motion. All those in favor, say aye. Great, well, the minutes are approved. I don't have much as far as a committee chair report, other than to remind everyone today, if you're speaking, to make sure that your microphone is on. Otherwise, the 3 people watching on YouTube cannot hear you, and we want them to certainly be able to hear. We might get to 8 on YouTube. I'll have Mr. Norwood give us an update on that as we proceed. Also, several of the board members have already met with Ron regarding enterprise risk management and kind of an update as to where we've been and where we're going. He really needs to speak with all of us as board members, so if you could please get in touch with him or respond to his request for about 30 minutes of your time to just get an update on ERM, that would be much appreciated. And with that, we'll move on to item 5 and an ERM update. Mr. Skillins.
Make sure it's turned on. Okay. Good afternoon. Thank you, Mr. Chair, about the interview process. I've gotten some great feedback from executives and some board members, and I know you all are busy, and so if it's more convenient for you guys to speak with me via conference call, I can arrange that, or I can come to your office. I know I did that with DT, and it was very delightful. So
I'm not beyond public shaming either, so.
So what we have today in terms of update is first to talk about some of the activities that we've been doing since we last met in the ERM program. So one of the things we talked about at the last governance meeting was how do we know that we're progressing in these 10 or 11 areas that we've been talking about over the last 18 months? And so the team has spent some time developing a criteria, which I'll show in a minute, of how we are determining how we're progressing against each of these 10 areas in terms of how mature each of these areas are. And so I'll be showing you that here in a second. From a new area of risk, I think we've mentioned cybersecurity as being one of the key areas that was added as our 11th area of risk. And so we're going to have David Mendenhall, who I understand is wearing a coat and tie today, is going to speak about cybersecurity board training and give a brief update on cybersecurity. As Chair mentioned, I'm conducting risk assessment interviews. I've interviewed probably half of the executive team and probably 4 or 5 board members at this point, and getting input for the August meeting where we'll come back and present our annual plan, as we do every year, for fiscal 19 for both compliance and internal audit. And then we'll be doing an organizational risk assessment survey through a software package that we have that will, to the broader population. So we can't just limit it to the leaders. We want to kind of get feedback from the broader workforce. And so that will be going out here in the next day or two. It will be a brief 7 or 8 questions with a couple of open-ended questions at the end to get input from overall JPS workforce and staff. And then lastly, we did a brief ERM overview at Leadership Connection, which is the mid-level manager meeting here in this room. So overall, we've been staying busy. I think we've been making progress in each of the areas, and I'm looking forward to meeting with the new leaders, the new senior team members that have joined JPS in recent months to get their perspectives on each of these areas. This next slide is just a depiction of the new list of the ERM risk areas that include cybersecurity there at the bottom. The only thing in addition to that I'll point out on this slide is that what we had agreed to is a 3-year assessment period for these. These are big areas. Many of them are all interrelated with one another, particularly quality and a number of these other areas. And so with the exception of cybersecurity, we're in a 2-year mark with each of these, and so we have another 12 months before we do a complete reassessment from an ERM perspective. And so just wanted to show you the updated list. This slide shows what our maturity criteria will be with respect to each of these 11 areas and how we're going to evaluate them in terms of how we're making progress. One of the things that I showed last time was related to the crescent graphic at the bottom. Each of the ERM areas has a maturity graphic. And I did include the scale in the packet, so that was a question last time as well in terms of what each of these 5 levels mean from initial to optimized. And the graphic shows a black line or black arrow that gives a baseline of where we are 2 years ago when we initially started the journey in terms of maturity for a particular area. Now, this is just an illustration. This doesn't reflect any given one. This is more of an illustration. And then the green arrow indicates our current state, where we are, where the executive and the owners of a particular area is today. And then the white star that's on this depiction on the in the defined section is where the desired goal. And so as I present these to you and get updates from the senior executive team and they come up and present their areas, what we're hoping to do is move the green arrow over to the right to accomplish the goal or the desired goal over time. And how we move the green arrow is with looking at these 3 areas on this slide. So the first is metrics. So these are already defined by JPS. We've talked about these. These are our various metrics that are in our AIP goals, destination metrics, and others, whether it be quality, physician, patient, employee engagement, and others. Projects, these wouldn't be all of the sundry projects in a particular area, but it would be certain key projects that, as they get completed, are they helping us achieve our goal? And then risk management capabilities, these are more the internal processes, policies, technologies associated with each of the areas. So
let me give you all a bit of a clarity to this, because I know some of you have not met with Ron, and thank you, Mr. Chairman, for mentioning that. When he speaks of maturity, he's talking about the graph. It's not the reader of the graph. It's just the graph. So y'all don't be fearful of meeting with him because he's not judging any maturity levels. It's just all the graph. Just want to make sure y'all
Thank you
knew
for
that.
clearing that up.
I just want to make sure that y'all would still meet with him.
thank you, Robert. I appreciate that.
Ron, I appreciate you adding the baseline to the graph because of all the metrics that we see, this is to me, is by far the easiest for us to take a quick, immediate look at to see where we've been, where we're going, and where we currently are.
No, absolutely.
Welcome, Reverend Emerson.
This next slide is just the risk maturity scale, and this just shows what each of the maturity levels for the areas are in each of the 5 areas. So without, before I have David to come up, are there any questions before I have David to touch on giving a cybersecurity update? Okay, all right, David?
To where we are today, light years.
It's great.
Light years.
Reverend Emerson, and by the way, you are perfectly on time. We started the actual meeting on time today, so you're not late technically.
I'm glad he's here.
Me too. Great, thank you very much. One of the things that we do technology assessments here all the time, and we do cybersecurity assessments. Ever since I've been here, we started this practice of making sure we have outside companies come in and test the validity of our cybersecurity practice, as well as our technology abilities to stop any type of attack. This last year, though, when we did our assessment back in January of this year, one of the findings of that assessment was that we did not do a good job of informing the board of directors, the board of managers, what our status with cybersecurity is, and we don't do a very good job educating our leadership about what cybersecurity is. So this will become, and that's when Ron and I had a chance to sit down and talk about how do we add this as a risk stature at JPS, And how do we then put together some education for not just the board, but for leadership and employees ongoing? So this is kind of part one to several parts that will be coming to the board. This is just an overview. It's not to get into the weeds about every piece of technology. We could do that if you wanted to, but I don't think that would be great for this conversation. But this is kind of just an overview of where the organization sits from a cybersecurity perspective, as well as the industry sits as we go forward. So we're just going to do a quick overview and talk about some breaches that have been out there, as well as our technical attributes. So some of the challenges that we're having inside of healthcare right now is, as you guys have noticed, just like every other industry, we are pushing toward electronic everything right now. We're pushing toward interoperability. Information, it lives inside of our walls, but it also lives outside of our walls. And when you look at the industry right now, 10 years ago, as long as we put a brick walls around our data center, everything would have been fine. But now we have to talk to all of the other hospitals that are out there and share information. We have to talk to residents that are coming in that have a different thought pattern of how technology should be used, as opposed to more mature physicians that we might be dealing with. Our patient engagement is also escalating to where, with my chart and a lot of other technologies that are out there, our patients want to see their electronic medical record when they're at home. They don't want to see it when it's here. As well as our employees are changing. And Pia talks about all the time, Pia Walker talks all the time on how we are changing our generations here. And when we have a 40% millennial generation that was born with a smartphone in their hand, that changes what we have to do with technology and how we have to get information to our employees as well as our patients. When you look at some of the technology enablers that are out there that are enabling some of this transformation, we talk about cloud technology and smart devices, Internet of Things, remote technology. One of the biggest things that's hampering us as technologists in security is the highly skilled workforce that we're dealing with. Again, 10 years ago, if I as an IT person could sit at a laptop and show you a couple of things, you thought I was a smart guy. Now things are changing to where when I go to someone, they have 15 different ideas on how we can make technology better. Then I have to go back and figure out, is that a secure way to do that? Is there a manageable way to handle that? And the highly skilled workforce is really challenging because we have to challenge all of our paradigms as well. So let's talk about cybersecurity today. Today, we're not just dealing with the kids in their basements or in their garages that have a computer and they're trying to hack through. Statistics are showing that 43% of the data loss that's happening right now happens because of an internal threat, which means an internal person purposely took information and found a way to get it out of the organization and either sold that information in the dark web, or took it and they used it at home, and maybe then they got breached with a virus. So we're not just dealing with people that are trying to attack us. We also have bad actors inside of our walls that are taking data from us. So we have to, this isn't, when I say from us, this is an FBI report. This isn't a JPS report. This is what statistics are showing. We also have computer intrusions that are saying that if less than 10,000 records are breached, that's usually about a $4.9 million cleanup at times. If over 50,000 records are breached, there's an average cost of about $13.1 million. So we manage close to 2.5 million records here at JPS. So you can imagine what that dollar amount would be if we were to lose our patient database, if someone were to come in and hack us and take that information. Those are the costs that it takes to clean all that information up. From business email compromise, that usually comes through phishing attacks. And I don't know if you guys know what phishing attacks are, but let me kind of talk you through that process. A phishing attack is when someone sends you an email and then you click on a link that really is a bad link. It's a link to another website or to another thing that will force you to give up your information, or for them to remotely attach to your computer and take over your computer. What's interesting about that is we did 2 exercises here at JPS. One we did a couple weeks ago with our new residents that were coming in, and I was giving a cybersecurity overview. And this week on Tuesday, we did it with our leadership. And I just put up a keyword on the screen. I said, everybody text this keyword on your phone to this phone number. And everybody, just because they trust me, they trust my smiling face, they texted to that keyword within a couple seconds. And then within about 2 seconds after that, I sent them a link, and just automatically they received a link, and they clicked on that link. Of the 100 leaders that were in that room, within 15 seconds, 50 of them had clicked on that link, and I had all of their information. I had their phone number, I had what they were using as far as their AT&T or Verizon or T-Mobile or whatever. I had everybody's name that was on their plan, and so on and so forth. Now, that was a great thing to be able to show how quickly a phishing attack can escalate. I'm not going to do that to you guys.
That's why you had all those shopping carts.
Absolutely, absolutely. I went shopping at Toys R Us. Everything's 80% off at that particular point in time, so I did that. Now, what was interesting is I was patting myself on the back going, ha ha, isn't this wonderful that I was able to attack all of my leaders all at one time, until Robert stepped into the equation. And Robert, since I was talking about hacking, he hacked my presentation right in the middle of that presentation and put up a slide that showed a fictitious Social Security number and said, this is David's Social Security number. And he thought he was really funny. And so what was really interesting about that is he comes out of the room and says, you hacked everybody else, I hacked you, we're even. So it was a very interesting thing. But I'm not going to do that to you, but it was an interesting exercise to be able to show how quickly someone can get hacked and you don't even know that you're doing it, right? So ransomware is something that is hitting all of the periodicals and all the internet sites right now about something that can happen that can take your system down. And basically what ransomware is you find yourself in this situation where all of a sudden your computers become encrypted and you can't do anything about it. And so you might be trying to look up a patient, you might be trying to do an email, you might be trying to do something that you would normally do. All of a sudden your technology goes down. And it's someone on the other end that is now wanting dollars from you to be able to unencrypt that device. And that's a very scary thing when you look at that. How much did Robert want? He wanted just some kibble for his new dog, and that was great. I was able to get that for him. So about 80% of organizations right now are saying that they have seen some type of ransomware attack. Big organizations are seeing it pervasive through the entire organization. Some people are just seeing it on one computer. Either way, it's all ransomware. So targeted data, what are hackers looking for when they come in? They're looking for several different pockets of information. They're looking for personal identifiable information about the individuals that are working for an organization. They're looking for protected health information. I'll come back to that in just a minute. They're looking for intellectual property, payment card industry information like credit cards. They're looking for business intelligence, MNPI, which is material non-public information, some trade secrets, those types of things that you might be having on your computer systems, as well as defense and national security and critical infrastructure. So since we're a healthcare organization, let's talk about that purple bubble that talks about protected health information. Hospitals right now, when you look at the attack surface that's going through the industry, right now hospitals are seeing about 50% of the attacks that are happening in healthcare compared to every other industry that's out there. So when you talk about finance and banking and retail and globalization and all the federal governments that are out there, over half the attacks are hitting healthcare organizations and not all those other organizations. And the reason why is because we have such a rich data set here. So when you look at all the data that we have here at JPS or any other hospital, we know your name, we know your Social Security number, we know your health insurance information, we know your next of kin, we know your address, we know where you've been for the last 5 years, we know your payment, we know everything about you. We also know your surgeries, we know your clinical history, and that data sits at rest for a very long time. Target, Home Depot, all of those places, your transaction, the information that you have is very transactional. You swipe your credit card, if you get that information within a few minutes, great, you can hack that credit card. But on the dark web, which is where a lot of this information sits, that credit card information is only good for a couple of hours, maybe a day. But if you see something show up on your credit card, on your online payment to your credit card, you're calling your bank. And they're going to get that rectified. And they're going to take a look at that, and they're going to be able to issue you a credit card. When someone hacks a hospital, a lot of times we don't know that we've been hacked because those people sit there for 6 months at a time trying to get as much information as they possibly can because of the rich data that we have here. Then they put it out there. And the reasons why they put it out there is very simple. It could be identity theft, but more to the point is maybe they want your insurance information. Maybe they have a surgery coming up, someone can buy your record out there, and if they have a similar background, they can take your insurance information and be able to get you to pay for their surgery that they need to have. Or if you've had maybe $200,000 or $300,000 worth of medical care in the last year, they can see that and they can take that and use that for tax fraud reasons and claim that as their own. There's all types of reasons out that. Statistics are showing that protected health information on the dark web right now goes for almost $500 per record that's stolen, where a credit card or Social Security number now only goes for less than $1 out on the dark web. So those are some things that you have to keep in mind and why I don't sleep a lot and why we do a lot of these things, right? So let's just talk about real quickly about what the anatomy of an attack would look like if someone were to try to attack JPS or any other healthcare organization. There's some initial recon that happens, and then the initial compromise. And that recon happens in ways that we don't normally think of. And I put some icons up there about LinkedIn and Facebook and Twitter. And here's just a quick anecdote about what happened. This last year, when we had an assessor come in, we had them come in and do some social engineering exercises. With social engineering can be a phishing attack, but social engineering can also be, let me pose as a JPS employee and see how far I can get into the system to be able to get electronic information, be able to get protected health information. So we paid an organization to be able to come in and see how far they can get with social engineering. They went out onto LinkedIn and to Facebook. They saw all of our happy faces wearing our JPS badges out there on the social media sites. They took that, zoomed in, copied that into Photoshop, went to Staples, and then printed out something that looked like a JPS badge. When they did that, they Photoshopped their picture on it, their name on it, and laminated it. And then they started walking into our facilities pretending they were IT employees. And they were able to get everywhere without much challenge. They were able to sit down at computers. They were able to get into our systems. In fact, people thought they were IT employees and asked them to fix printers while they were there. They asked them to fix some technology issues. They thought they were IT people. Never challenging who's your boss, who's your manager, what's your employee number, those types of things. So we're going to, that recon happens every day, and that's when the initial compromise will happen. Yeah.
Are the employees made aware to raise those questions?
That's what we're doing now. This is only the second time we've done this type of thing, and that's when we got hit that we are not educating our employees well, and that's where we're going to change. Exactly. We can change our badges every day to a different color, I guess. We could do something like that. But also what's interesting in healthcare, one of the reasons why we're getting attacked is we don't see the same patients every day. We don't see the same family members every day. And we expect to be a transitory organization. And so we don't always know when new people are coming in or people should be or shouldn't be here. So we're going to kick up our education about making sure those challenges are done. It's a great question. Then establishing a foothold, then they escalate privileges, then they do some internal recon of what they can do, then they move laterally. That's the biggest issue that's happening inside of IT organizations right now, is we don't always know when we've been compromised, and people can move laterally from system to system to system to figure out what's going on. Then they can expand their presence, exfiltrate the data, and then maintain that presence as long as someone doesn't know that they're there, okay? That's what happens. Quickly, some notable healthcare breaches that have happened just in the last 6 months. These are all in 2018. And I chose several different ranges here. This is not an all-encompassing list. These are just ones that have some different things that are going on. All the way from Calida Health that had 774 patients, and you think that's a relatively small number, but the HIPAA statute says any breach that's over 500 patients has to be escalated to the OCR. And so they had to escalate, even though they only lost 744 records, they had to escalate that to the OCR and put in a thing in there. When I was talking about phishing is what happened with them. And as you go all the way down, there's a lot of different reasons and causes for these, from a breach to ransomware. But when you get down to the bottom and you talk about Molina Healthcare that lost 4.8 million records because of a security flaw, Molina had that situation happen where a security patch was put out into the open from Microsoft, and they did not get around to putting that patch in place, and it took them about 3 months to put that technology patch in place. 3 months is not a long time to evaluate whether or not a patch is going to work in your environment, but in those 3 months, someone then compromised them and took all of those records from them, and they're going to get hit with a really big fine because that 3 months was way too long. Now for us, we patch within 3 weeks. We patch all of our systems within 3 weeks, and that's really as fast as we can possibly do that. We're very aggressive on that. Now the Bronx, Lebanon one was a very interesting one as well because they lost millions of records. In fact, they don't know how many millions of records that they did, and publicly they're not saying how many they lost because they really don't know. But what happened with them is their data set got so big they could no longer back up with traditional means all of their data. So they partnered with a cloud provider to be able to move their data off-site in a backup situation, and that cloud provider got hacked. And when that happened, Bronx, Lebanon then lost all of their data, and they got compromised, and they're still trying to get through that system. But that's just another environment that we try to keep things within our four walls, and we can try to protect as much as we can. But there's other technologies that we're opening up to that may be compromised as well, and we just have to be aware of that as we go into those risky situations. For you, for the board, here's some principles that we definitely want you guys paying attention to over the next year. And as Ron said, this is going to be a 3-year thing that's going to show up on our enterprise risk management portfolio. And here's some principles just to keep in mind for you guys. Number one, cybersecurity is an enterprise risk management issue. It's not just an IT issue. If I were the only one that was responsible for it, then, well, you're not going to get very much value out of me. I mean, with the social engineering aspect that I just talked to you about just someone spoofing a badge, I can't be at every exit, about every entrance, and so on and so forth. We got to develop a culture that everybody's aware of this, and it starts with the board and leadership on this. Understanding the legal implications of cyber risk to the company. Here's just a quick thing from that. MD Anderson, a week and a half ago, got hit with a $4.8 million fine from the OCR for a laptop and a cell phone that was lost back in 2012. So 6 years later, they're getting hit with a multi-million-dollar fine because someone lost a cell phone and a laptop. And those are the risks and fines that when we look at this industry that we're really against. And we can gripe and complain that maybe that's too big, but that's really where OCR is trying to crack down to say, look, healthcare, you've got to do a better job of securing all of your assets. For a board, you have to have adequate access to cybersecurity expertise and discuss risk management regularly in board meetings, and that's what we're going to be doing. Another principle is to ensure the management establishes the risk framework, which is what you're doing with adequate staffing and budget, and Ron and I have been working on that. As well as during board meetings, we have to have open discussions and not be afraid of this risk that may come up and potentially identify risks that are coming up in the environment. Now, from a JPS perspective, we do lots of different things, and from a technical perspective, to make sure that we keep all of this data as secure as we possibly can. And I'm not going to read all of these things. It's in your packet if you want to be able to see it. But we do a lot of things about cybersecurity, but understand that each one of these things that we do, we're one click away from somebody doing something that may put us in harm's way, or we're one patch away from not putting those on our systems that a hacker could come through and take advantage of us. So from perimeter defenses and internal network defenses, host defenses and application defenses, as well as data defenses that we have in place, these are all the things that we try to do on a yearly basis to improve these systems, as well as we could do continuous monitoring and policies and procedures, as well as threat intelligence and security risk assessments. The biggest thing that we do on there is that bottom orange bar that talks about risk assessments, and we pay every year, as I said earlier, people trying to come in and hack through our networks, and those are great learning experiences for us. So, any questions? I know I breezed through that, and like I said, this is like part one of many, but do you guys have any questions for me?
I do.
Steve?
Yeah. And you talked about risk, and there's obviously risk of fines, but there's also litigation risk.
Yeah.
For the people whose information gets taken. In terms of mitigating those risks, do we, and maybe a question for Sharon as much, do we do cybersecurity coverage, health, insurance?
Yeah, Ron's actually in charge of our cybersecurity insurance.
Yeah, I know in finance every year we go through the renewal process, and I think you actually brought up this question last year about our level of coverage in cyber, but we, our coverage is with Beasley, and Beasley is one of the foremost providers for this type of coverage. We have a $10 million limit currently at JPS, and so one of the things that I'm asking the broker to do based upon your comments and others from last year is how much does it cost possibly to get additional coverage beyond the $10 million? And of course, they'll never answer the question how much is enough, because that's kind of a nebulous question. But the thing that's good with Beasley is that having been through a breach like this, and I've used their service unfortunately in another place, is that $10 million covers the immediate losses related to the breach in terms of fines and penalties like we're talking about. But there's a whole nother bucket of liability associated with the legal costs, the forensics, the internal costs, and other kinds of things, that there's a kind of a separate bucket within that same policy that covers that, which is unique. It doesn't go against the $10 million cap, because as you saw in some of these fines, they can, you can get potentially how many records you lose, you can get to that fairly easily. So we are looking at that.
And then there's a whole other layer of reputational risk, right? I mean, would anybody come here if they had an option not to, if they knew it was a risk?
And that's what you're seeing with like Equifax and a lot of those big companies that lost millions of records. In fact, there's a new one that just came out this morning. There was a company that Equifax was working with prior to the Equifax breach that actually had information I think the number was 3.4 billion people. That's half the population of the earth. They had 3.4 billion records on their systems, and they got hacked earlier this week. And so they're trying to do that cleanup. So a lot of these aggregators, a lot of these companies, when we start looking at the risk just gets bigger and bigger and bigger, not just from the dollars, but the reputation. Because who wants to use Equifax now, right? Nobody wants to use that, and they've lost billions of dollars because banks don't want to use them as that credit intermediary any longer. So those are the things that have to be done. Target took such a hit when they got hacked that they lost almost 30% of their business, their retail business, over the course of 12 months because of their hack. Home Depot did the exact same thing, and they took a huge hit. So there's huge reputation risks that happen with this. You got it.
And actually, I mentioned this at one of the prior meetings, but when I go to these ERM roundtables for other organizations, and many of them are outside of healthcare, many of them are in banking in particular, when they go through their risk profile, many times because of the agenda of the board meetings, there's very limited time to talk about these things, but one of the consistent themes that they always talk about in these risk discussions is this one in cybersecurity, whether it be Southwest Airlines or Chase or whomever else, because of because of the proliferation of this and the liability associated with it. So I think it's certainly a worthy addition to our list.
David, I had approached you some time ago about cybersecurity. Right. And the reason I did at that time was because I was at a board meeting and for AHA, and they kept emphasizing to go back to your organization and see if they are connecting or coordinating with the Justice Department. And that's why I asked. I didn't ask you if we had. I really asked to see what your response was. Right. And do we do any of that? Because they kept emphasizing we should.
Yeah, no, that's a great question. And I remember when you asked me that question about what do we do, and that question really is what brought us to this point today, because we realized very quickly we had not done a good job of educating you all. We do coordinate. In fact, Ron and I are running what's considered a mock OCR audit right now, where we've hired a company to look at our organization about the way the OCR would look at our organization from a cyber perspective to make sure we're doing all the things that we should do. We also coordinate with AHA. So I'm on the THA. I'm on the Texas Hospital Association's cyber team to make sure as hospitals are coordinating as well, to make sure what are you doing, what are you doing, what are you seeing? And we have those calls once a quarter to make sure we're all in sync about new threats that might be coming in, new fines that might be levied, so we all understand and have a good education around that. So yeah, we are definitely taking that approach to make sure we're not sitting on the outside of this. Great question.
Any other questions? I don't know how you sleep at night, David.
I don't. Thank you.
I'm kind of terrified now.
Yeah.
I guess my question, Ron, on our destination metrics, cybersecurity's on there, but those are not listed in any particular order.
Not to my knowledge, not.
Okay, so they're all of equal importance as those 9 pillars, so to speak.
No, are you referring to the ERM areas or the
yes.
destination? Yeah. Oh, yes. In
Yeah.
the ERM areas, those are listed based upon this group's prioritization of those, but we didn't list them in 1 through 11 order, so they're not in priority order. They were just the 10 areas that out of the 50 that we started out with from a couple of years ago.
Okay. I was just curious. Today, it really stresses me out.
Yeah. So I think I hear what you're saying. So,
yeah.
So it don't imply that because cybersecurity is at the bottom of the list.
Exactly.
That it is a low priority.
Right.
All of those areas are high priorities, and that's the reason why we're using maturity to gauge our progress as opposed to saying high, medium, and low, because all of them would be high if you did that way.
Well, and if anybody in the audience gets a text from David.
Yeah, don't click on it.
Call him back. Thanks, David.
I have a question.
Appreciate it.
One question, Dr. Hyde.
Oh, yeah. You may have covered this and I missed it. But has JPS, the Texas Hospital District, been hacked and lost data?
We have not. We have not. So that's a great question. Now, that doesn't mean that...
As far as we know.
Right, as far as we know. And we'll talk in closed session about some of the risks that we've identified and some of the things we're going to be talking about. I don't want to necessarily do that in open session when the 4 people on YouTube might be listening to us. But there are some risks. There are some times we've gotten hit with viruses and so on and so forth, and we brought people in to ensure that we did not lose one record of data, and we do have their certifications that we didn't lose one record of data with that. And those are the same forensics people that all these other hospitals bring in to see, did we lose information? So no, we have not lost any data. Okay, great. Thanks, guys. Thank you.
All right, Ron. Compliance program reports and updates.
All right. Well, I think David did an excellent job in kind of scaring us all, and I certainly don't want to add to that with this slide, but.
But let's begin.
But since you were here.
But, so I won't belabor these points. But as I always do, I try to pick areas that's happening in enforcement actions with the government that have some pertinence to areas that are practiced at JPS. And so this first one is a suspension of Morrison-Dixon to sell controlled substances, controlled drugs to its customers, which JPS is one of them, because of them not identifying as an outlier purchases of a particular drug manufacturer, or actually a drugstore chain, believe it's in Louisiana, that had a high volume of purchases of certain controlled substances. The DEA felt like Morrison-Dixon should have been a red flag, and they should have asked additional questions when these high volume of drugs were sold. However, I just got an update last week that this case was dismissed. The DEA actually suspended them, which would have meant that JPS, as a customer of Morrison-Dixon, wouldn't be able to get our drugs from them, and so they had the suspension was postponed during this trial, and I just got word, and I got confirmation from Nicole Shoquist that this was now dismissed, so it's no longer a risk, and they can continue normal operations. But in case you were wondering if it wasn't dismissed, we did have a plan B in terms of looking at other wholesalers, and I did ask that question of our pharmacy folks. The second item is a Texas-based radiation therapy company by the name of Sightline that was fined $11.5 million for allegations of violation of the False Claims Act. And basically, this was a violation of not only the False Claims Act, but also the anti-kickback statute. And so you had a number of claims that were essentially for services that were not rendered. And this is becoming more and more common. The government is continuing to find cases in this nature. The next case is Gainesville Hospital District in East Texas was self-disclosed. Actually, one of their physician leaders was being compensated above what was considered commercially reasonable and fair market value, and they self-disclosed. So, which in many cases, when you self-disclose, the fine is much less because you've identified it yourself. And so they did end up paying $1.3 million, but it would have been higher than that if they hadn't identified it themselves. So that's the benefit of self-disclosure. And then in this last case, it's a really heartbreaking case in McAllen on the border. There was a physician who is a part of a group, a bunch of co-conspirators that essentially was misdiagnosing on purpose vulnerable populations, whether it be elderly or children or others, saying that they had certain types of cancers and diabetes and other kinds of things, and then giving them chemotherapy that they didn't need, as well as other kinds of treatments that they didn't need, and then billing Medicare for it. And it was just so egregious, and it happened over many years of time, and this was apparently a sting operation that this physician, along with his co-conspirators, profited. And the reason why it says international money laundering is that they purchased properties in Mexico and other places with this fraudulent money. So it was just an unconscionable type of thing, but that happened in a couple months ago. So again, not to say that any of these things are necessarily happening at JPS, but this is kind of an example of the reason why we need to continue to stay vigilant in areas, particularly in our work plan. Questions on any of those? Okay, all right. So good news. We have a new compliance director that I wanted to introduce to you today, Ms. Yolanda Rich. I'll have Yolanda to come up if you could. Yolanda joins us with over 25 years of compliance experience, and I'll let her speak for herself here in a minute, please. Let her speak for herself, but joins us by way of Alabama, which is a long tradition of executives from Alabama. I won't mention who. But also was the vice president of compliance at Grady Health System, which is in Atlanta, the large safety net hospital in Atlanta, and was also the vice president of compliance at Parkland in Dallas as well. So, Yolanda?
Well, thank you, Ron. This has been an engaging 6 days. I started last Wednesday. I had the opportunity to join Ron and his team at their off-site divisional meeting and learned about the great things that they are doing. And then new employee orientation was equally awesome and exciting. And yesterday, I believe it was, no, Tuesday, Leadership Connection, all the wonderful things that are going on at JPS. So this is an exciting time to be here. I'm really thrilled to be here and looking forward to working with everyone.
She will periodically check in and make sure she still has that attitude.
Well, I'm from Alabama, so it's Roll Tide, so.
You had to say that.
Neil's not here. This was your free pass. Neil Adams is not in the room. This is your free pass.
Just so you know, I'm not from Alabama. I mean, I'm not an Alabama graduate. I'm a University of Montevallo, which is a little small town in Alabama.
Don't try to get out of it now.
Thank you.
Yeah, thank you, Yolanda. Yeah. So going forward, I'll be working with Yolanda. Yolanda and I will be co-presenting the compliance section of these meetings going forward, and definitely looking forward to that. HRSA was here, the regulator over our 340B drug program, and they did an annual, or it's not annual, but they did a routine audit of our 340B program. Unfortunately, given that they're the government, they don't have any time frame to get back with us on how we did. But our folks, our pharmacy folks, as well as the compliance folks that participated with them, indicated that we did really well with them. There was a few recommendations that the auditors had when they were on site, but they could have up to a year to get back with us on the report. So we won't actually know for sure, close to a year. And so, but there's no time frame on them. But the team did a really good job. I want to commend Nicole Showquest and the pharmacy team, as well as the number of others that helped, in addition to my folks, in the work that they put forth in that, as well as our consultants, Poneman, that was involved in that process. IMRT, intensity modulated radiation therapy, we did a compliance audit in this area, which I'll brief in closed session. And then we are currently working on compliance coding modifier updates. As y'all remember, we, in our coding auditing area, are looking at these modifiers, and we're doing a follow-up audit in these that are underway that'll be briefed at a future meeting. As David pointed out, we are close to completing the HIPAA mock audit, and we had a vendor to help us to do social engineering, to look at the HIPAA privacy and the security rule to ensure our compliance with all aspects of privacy and security. And they were here for 4 days on site. They walked around the facility to see if they could get in places they shouldn't be able to. Now, in this case, they weren't the people who copied the badge and walked around. They had a get out of jail free letter so our police chief knew that they were here, but the officers didn't. I knew, and Jamie knew, and some others. And so our security staff did really well in stopping them at the right points. And so they did a very commendable job in the social engineering aspect. But they did identify some areas that we can improve in. So I'm going to, once we have that report, we don't have it quite yet, I'll brief that with you all as well. Questions on any of that? Okay.
All right.
So that concludes the compliance report.
All right, Michelle, if you could talk about internal audit. Oh, go ahead, Dr. Weber.
Tessa, you asked if there was a plan B, and you never gave
Morrison-Dixon. Morrison-Dixon. What is our plan B? Or a plan B, if they would not have prevailed, is the pharmacy folks had identified some alternate wholesalers that we would have purchased drugs from if that would have been an eventuality. But fortunately for us, that case was dismissed, so we, yeah. But no, that's, I mean, because I asked that too, what if it hadn't have happened? Yeah. I'm sorry, yep.
Looking for the microphone.
Oh, it's right there.
This is the microphone?
Yes, ma'am.
Hello? Okay, we're good. Okay.
Obviously, that's not something you've audited.
It is on the
You're
new work
wrong.
plan.
Okay, so as usual, internal audit has a very short open session today. What I did is I went ahead and listed all 14 projects we had on the 18 plan for you, just to kind of recap for the year. We had 7 new projects and 7 follow-ups. As you can see, today being the 28th of June, we'll have 4 projects to brief in closed session. And for the next 2 board meetings, completing out the 18 projects, you can see those listed here. Outside medical services is our next new project that you'll hear from. And then call center operations, we have not started that yet, but certainly that's around the corner. I did want to make a note at the bottom where on the August 23rd meeting, that's going to be a meeting where I may not be here. So Ron's going to do the honors and propose the new projects on the 19 plan. And just to level set expectations a little bit, I just wanted to mention, we know we had 14 projects this year, and that was a pretty aggressive, nonstop audit after audit after audit for the team. And I think next year what we want to do is slow down just a little bit, start to build in some continuous monitoring and auditing in the process. So after we conduct an audit, we're going to design and build a way to continuously monitor the outcomes of that audit. Does that make sense? So the follow-up doesn't occur a whole year later, okay? So just wanted to kind of level set expectations on that. You probably won't see 7 brand-new projects next year. It'll probably be more like 5, okay? Any questions that I can answer before moving to closed?
I just want to say, Michelle, you and your team that's an incredible amount of work.
Thank you.
And it seems like a long time frame, but it's really not, considering all the different factors and everything that goes into a single audit. So I commend you guys on that, and I really like the plan to have a long-term solution to continue to follow these audit reviews.
Awesome.
Really like that.
Yep, thank you, sir.
Anybody have any questions? We will move to closed session at 12:50, and we will get started here shortly. So there you go. All right, we will reconvene in open session at 2:36 with no further business of the Governance Committee. We stand adjourned.